Right, so we're going to quickly open it up to questions again. We've got about 10 minutes for some questions, and then you can have your lunch. Who wants to go? Look at these sneaking out first. The cling film is still on the butties, don't worry. You're not getting in there any quicker. Has anyone got any questions? There we go. Yeah, we'll go here because that's near, and then we'll go there next. Get ready. There we go.
Well, at least you know I'm not going to slag you off, Alex. I wonder if I could have your opinion. Perhaps this is a rhetorical question, so I hope it doesn't sort of blow up in my face. But in the real world at the moment, when, dare I say it, perhaps people are taking steps to avoid Section 117 responsibilities, by, particularly with the elderly, going down the standard authorisation route, bearing in mind that most authorities have a delay in issuing standard authorisations, and bearing in mind that which you choose, you should be looking at the least restrictive option, would you accept that it is less restrictive to use the Mental Health Act every time if by using the Mental Capacity Act there is at least a period of unlawful deprivation of liberty?
Is that mic on?
Microphone? Oh, now it is. I'd have to charge you, Peter, for giving a real answer. What I would say is I think one of the massive problems with the current situation is that people are being driven to the most perverse conclusions as to whether it's the Mental Health Act or the Mental Capacity Act by a whole series of criteria. It should really have absolutely nothing to do with anything at all. And you've got the massive Section 117 lurking over at least some form of decision-making. You've also got, as you say, is it worth saying, or is it better to say in a kind of globally less restrictive of rights and freedoms to have a limited or no unlawful deprivation of liberty period versus using the MHA, which is said to be stigmatic? I would like to ask, by the way, where the evidence is that being deprived of liberty under doles is not stigmatic. I certainly get enough calls from hospices or from family members of people who've died under doles who I think would strongly suggest that they don't think that doles is a wonderful thing either. So no, I'm not going to answer, I can't really answer your question directly, except to say that it's a profoundly disturbing situation that for a whole series of frankly unforeseen events, we've got into a position where what really should be a relatively sensible and, in my view, quite sensible underlying policy. In other words, if you are somewhere because you are really a mental health patient, you should use the Mental Health Act. And if you're somewhere because you're not a mental health patient, you should use the Mental Capacity Act, which was what the government actually was trying to do, is now just being completely perverted all over the place.
Well, we've got the next question.
This isn't a question, it's an observation, and it relates...
It's not allowed then. Next.
Fair enough. Shall I give it back? It relates to the safeguarding. I had a very long conversation with somebody who works as a cleaner in a care home the other day. And she described how the behaviour of the senior supervisor particularly, but the care workers in that home changed as soon as relatives or social workers or anyone who was inspecting walked through the door. She described how somebody would literally run round the building saying, "There's somebody here." She described how she had observed the behaviour of the staff change, and she described behaviour which was abusive. I tried to encourage her to alert this to the care home manager or to the local authority, but her response was, "The manager is weak, that's why it's a problem." And she has got her own little campaign of saying, people are watching you, so that it goes back to the people who are doing this. This is entirely, in my view, unacceptable, but I wasn't unable to establish where she actually worked. So I'm now left with a dilemma of trying to find out, and I've been trying to think over the last few days what to do with this. But it really raises very serious concerns about the behaviour and how it changes and how people protect what their activities are within a particular home which are abusive.
Thank you. Margaret, would you have any comments on that? Or?
This is not new. We know, do we not, when we have unexpected visitors in our own homes, we might whip round with a feather duster before we allow them in. It's a variation on that, but a much more worrying variation. Safeguarding has a mantra, which is it's everyone's business, which means no one can be asked particularly. For my money, I'm very, very committed to the much more compelling use of it's in fact the Holocaust education. I'm sorry, I can't remember the term of it, but their refrain is "Don't stand by," and I think that is much more compelling in the law in Wales. People have a duty, professionals have a duty to report. We get to see how that will be enacted. I've done some work with whistleblowers, and without exception, they said they wouldn't do it again because life was made so profoundly difficult for them in their working context. So we have a lot of recalibrating to do, and I think it does very much hinge on our public values. Sarah talked about the values that arise from spending time with people. I think something that the families of Justice for Jasmine, families would say is, would you want this for your mum and dad? And it really is that requirement to get into someone else's shoes, to compel us to think that there's a different way of doing this. And sometimes it does require someone to be alongside us. I think it's very difficult when you're in employment and you're dependent on a service for your continuing employment, and you've got a mortgage and a family, etc. But actually, the support of someone alongside you to help you do this is something that all the whistleblowers said that would have been helpful. So I think, thank you for doing what you're doing. You are assisting this person to think about the option of disclosing to people who can and should be taking action. It prompts me as well to think about cameras in homes. You may recall that some of the most dreadful abuses at Winterbourne View Hospital took place in bathrooms and toilets, where we should be most safe, where we expose the most vulnerable parts of our bodies. And yet I would resist there being a camera in such places. We know that when someone flashes a camera in front of us, we change. Our demeanour changes. We look ridiculous, frankly. And people who are abusive know this, so they simply avoid the cameras.
We've got time for one more question.
I'm afraid this is also just a comment, if I may.
Right, you're clearly not understanding what this is about.
Yeah. It's the accent. I'm Tom Burns. I'm a psychiatrist, and like probably 60% of people in this room, I'm paid and trained to compulsorily detain people. It's part of my job. I'm not in the least embarrassed about it. I wouldn't do it if I didn't think it had a positive purpose. The point I just wanted to bring up, because I've also had the grueling experience of having to read the hippie psychiatrist's papers on fusion and work my way through it, is the issue of the neutrality of language. Because when one's talking about the imposition of the Mental Health Act or the Mental Capacity Act, one's always assuming it's a loss. But actually most of us who do it day in, day out, do it because we think we're benefiting people. And I do think that somehow the discussion would have a slightly different balance if we use a more neutral approach to it. On the whole, it might be in people under the Mental Health Acts, it might actually be to their service that the threshold is slightly lower. And we assume that if the threshold is lower, that's to people's detriment. It's just that I do think that the language needs to be neutral, because most of us do this because we think it helps people. We also recognise there has to be oversight and control. And I'm very interested in your comment, if I just be very quick, about Section 5, because maybe things have changed since I trained and I was training junior doctors, but we always said you must never suggest that you will section somebody, because the moment you do that, you've put them under compulsion, and you should section them so that oversight can be brought into operation. When we were presenting that in our community treatment orders study to the ethicists at Oxford, they were outraged, because they said, you're not giving your patient truly informed consent unless they know it's at the back of your mind. But we clearly have a very different approach to that.
I would agree. Just check it on. Yeah, an awful lot of that I would agree. Just picking you up on that last bit, I think there are some real issues about the extent to which it's a little bit like the Montgomery decision about what you need to tell people in order to get informed consent to a physical treatment. And there are some real issues where I think we're still finding our way in terms of calibrating the information that is given by people who therapeutically are in a position of power, and you are actually in a position of power, which you are going to use in a therapeutic way. You're in a position of power as to what might happen, and you hold relevant information, and the extent to which you need to be giving, or what it is that you are doing in terms of relaying that information to a person. And we've got a model which says, as much as possible, we want to say this is all about two equally statused people having a equally statused discussion. And that's just, to my mind, completely untrue. If you're having someone who's profoundly unwell, who is going to be admitted for psychiatric assessment and treatment. And I think there is definitely work to be done because the code of practice and all the sort of published stuff says, obviously, no coercion, no whatever. So what is actually going on, which might be said to be unspoken coercion, well, don't do it. But at least if one is more honest about giving a framework within which you can say, this is the sort of information you do need to give. This is how you should be giving it. And if you are thinking about Section 5, I mean, if you're genuinely open-minded, that's one thing. But it's both a question of self-honesty on behalf of the admitting team, and also what is it that we think we should or shouldn't be doing in terms of having the discussion with the person who is, after all, the expert in being the person. And we're still finding our way, and it also gets very difficult to reduce some of this to easy. You can't reduce it to statute. It gets quite complicated trying to reduce it to easy language and code of practice, and it's then very capable of being abused. But thank you for raising those points, because they are important points.
Okay, thank you very much for that. So we're going to have an hour break now for lunch. Hang on.